So in the today's class we are going to discuss about venous disorders of leg, mainly DVT, varicose veins and related disorders. Okay. Uh, Before we start with today's class, we need to know certain basics of uh, venous system or venous drainage of legs, that is basic anatomy. So yeah, here is a diagram or a image showing venous drainage of lower limb. Okay, so what we need to know here is, just like we all know, venous drainage will start from the periphery and will come into the center. Okay, so from all these fingers digits, dorsal metatarsal veins will drain the blood and it will reach dorsal venous arch, which will in turn reach dorsalis pedis vein and anterior tibial vein and fibula vein. Okay, all these will reach small saphenous vein. There is one more vein which is draining almost anteromedial part of the leg, that is long saphenous vein or great saphenous vein. Okay, so this great saphenous vein is draining entire this portion, and other three portion, that is dorsalis vein, fibular vein and anterior tibial vein, all three will join short saphenous, which will in turn join popliteal vein. So basically two veins now, great saphenous vein and popliteal vein, these two are joining femoral vein at an opening called as saphenous opening. Okay, so this opening is called as saphenous opening. From here again femoral vein will continue and it will give some peripheries, some branches, and then it will join internal iliac vein, which will in turn join common iliac vein. So this is the drainage pathway. Okay, so in this again there are classifications, like we can say deep femoral veins and superficial femoral veins. So all the small saphenous vein, great saphenous vein are all superficial veins, whereas femoral vein, popliteal vein are deep veins. Okay, so now we are starting with venous disorders of leg per se, that is deep vein thrombosis. So what are the risk factors, or what is a causative factor for deep vein thrombosis? So just like the name suggests, deep vein has thrombus in it. Thrombus is nothing but a blood clot. So there is blood clot in the deep vein of leg, and that is called as deep vein thrombosis, right? So deep vein, just like we all know, femoral vein, popliteal vein, so and so. Okay, that can in turn anterior tibial vein, so and so. Okay, so basically there is blood clot in these deep veins. Because of that reason there will be a disease, and that is called as deep vein thrombosis. So if there has to be a deep vein thrombosis, according to Virchow, three main factors are essential. That is, you can say as Virchow's triad. First, like as we all know, a vein is lined by endothelium, which is nothing but flat squamous epithelium. So this is endothelium. Okay, so there should be an endothelium injury. So there is damage to this endothelium, so and so. Because of that reason, what will happen? As we all know, there will be blood flowing through here, and it will contain RBCs, WBCs, platelets, everything. So all these blood cells, whatever are there, they'll marginate and they'll try to repair this injury. And because of this reason, there will be a hypercoagulable state. Okay, along with this, since the fluid in the blood will leak out, there will be hemoconcentration. Like the fluid will leak out, and because of this reason only cells will remain here and plasma is less. Because of that reason there is increased or hemoconcentration, and there is stasis because increased viscosity will be there. So these three factors, like endothelium injury, which in turn leads to stasis and hypercoagulable state, these are the three factors which is known as Virchow's triad, which poses an increased risk or you can say a causative factor for deep vein thrombosis. So after that, what are the risk factors for thrombosis in general? Why does the blood clot in body in general? Okay, so these risk factors for thrombosis can be classified as inherited and acquired. So what are the inherited causes? Inherited causes, just like we all know, there are certain clotting factors which help in clotting in our body. Okay, if there is defective inhibition of these clotting factors, like clotting should happen only when actually bleeding is happening, right? When the bleeding is happening, in order to stop that bleeding, clotting should happen. Clotting should not happen when there is no bleeding. But if there is defective inhibition of these coagulation factors, it will be like it will clot when not needed. So that is the reason. So defective inhibition of clotting factors, mainly factor 5 Leiden factor defective inhibition is the main cause for thrombosis. Other than that, protein C and S deficiency. Just like we all know, these are clot cutters, you can say. Okay. So if there is a bleeding site here, there will be formation of a thrombus. Okay. After this endothelium or this lining has healed, this clot, whatever is there, should be dissolved. So for that reason, factor C and factor S will help. So these are basically breaking down the fibrin. Okay. So if these protein C and S is deficient, then fibrin will not be degraded. Okay. So this is the one which is accumulating like this and forming a clot. So these are fibrin strands, and these are broken down by protein C and S. In deficiency, these are not broken down, so clot will be more. Similarly, antithrombin 3 will aid protein C and S in cutting it. Okay, so basically these are clot cutters, that is protein C, protein S and antithrombin 3. So antithrombin, just like the name suggests, it will break down thrombin. It is against thrombin. Thrombin is the one which helps in clot formation. Sorry, clot dissolution. So antithrombin will help in clot formation. So these are the 3 inherited factors. Other than that, if there is impaired clot lysis, just like I said, once the clot is formed, it should be lysed so that again normal body physiology is restored. Okay, if there is impaired clot lysis, whatever the clot is formed, that will remain as it is. And when does that happen? If there is fibrinogenemia. So fibrinogen content is more in case of body. Okay, other than that, plasminogen deficiency. Similarly, plasminogen again helps in breaking down thrombin or plasmin, you can say. Okay, so if there is deficiency of this, clot will not be lysed, so more clot will be there. Similarly, TPA deficiency and platelet activation inhibitor 1 is excess. So platelet activate agadana inhibit ಮಾಡೋ factor ಇದು. Platelet activator inhibitor, you can say. So as we all know, platelet plays a role in blood clotting. So platelet na activate agadana inhibit ಮಾಡೋ factor. So if this is more, platelet won't be inhibited. So platelet will be more activated. That will lead to more clot formation. Okay. So platelet is not inhibited, or platelet activator is not inhibited, which will lead to increased platelet activation. That will lead to increased clot formation in the body. Okay. Other than that, there are certain uncertain mechanisms which cannot be explained, like homocystinuria and hyperhomocystinemia. These have been found that okay, in these conditions there is increased clot forming tendency in our body. Okay, so this is about inherited causes or inherited risk factors for thrombosis. Okay, what are the acquired risk factors for thrombosis? One is lupus anticoagulant. Just like this is autoimmune disease, so it is acquired. Okay, other than that, malignancies, myocardial infarction, infection, paroxysmal nocturnal hemoglobinuria, TTP, and nephrotic syndrome. In all these conditions, again, clotting tendency in the body will be increased, and physiological states like pregnancy, because clotting factors will be increased, except 11 and 13, that's a different issue. Other than that, obesity, there will be increased risk of having thrombus or deep vein thrombosis, prolonged immobilization after various surgeries. So again, this will lead to stasis of the blood in a lower limb, which will lead to increased endothelial injury, hypercoagulable state, and stasis. Again, Virchow's triad. Other than that, post-operative state. So all these states will pose increased risk for thrombosis. After this, what is the most common genetic cause for thrombophilia? What is the most common congenital cause for venous thrombosis? What is the most common genetic hereditary blood coagulation disorder? For all these, the answer is factor 5 Leiden mutation. Okay, yeah. Other than that, what are the surgeries that are associated with high risk for DVT? Basically, all lower limb or pelvic surgeries. Okay, so major abdominal or pelvic surgery, major orthopedic surgery, and urological surgery in the patients more than 40 years. Why does these surgeries pose an increased risk for DVT? Because of prolonged immobilization after these surgeries. Okay, for that reason, if there is prolonged immobilization because of gravity, whatever the blood is there, that will be pooling in case of, that will get pulled in lower limb, right? So if the blood is pooling in the lower limb, again that will lead to stasis, which is a increased risk for virchow striate. So other than, because of stasis, again there will be hypercoagulable state, and because of that there will be deep vein thrombosis. Okay, next. So how do we manage this? How do we treat deep vein thrombosis? There can be mechanical or pharmacological. Okay, mechanically, how can we treat the patient after this surgery? There will be prolonged immobilization. So we should avoid prolonged immobilization. For that, we should say early ambulation. Okay, so early ambulation, that is simplest. Other than that, we can use pneumatic compression devices. These are most commonly used, so that this will act like a mechanical pump devices. Okay, BP cuff raise ಮಾಡಿದ್ರೆ pressure ಜಾಸ್ತಿ ಆಗುತ್ತಲ್ಲ. Similarly, these devices are designed in such a way that they will raise pressure for certain time and then relieve pressure for certain time. So this won't allow the blood to get pooled in one place, and hence it will act like a early ambulation. Okay, one second. Yeah, I'm sorry. So these were the mechanical ways of treating deep vein thrombosis. Okay, pharmacologically, we can give anticoagulants like unfractionated heparin, okay, and low molecular weight heparin. So these are preferred because monitoring is not needed. Okay, so after this, coming to DVT prophylaxis. So how can we prevent DVT? Suppose we know that this patient is more prone, like the patient is now undergoing surgery or pelvic surgery or an orthopedic surgery. So we know that this patient has an increased risk of developing deep vein thrombosis. So how can we prevent it? Basically, we can do all these prophylaxis like pharmacologically. We can start unfractionated heparin before only. Other than that, we can say early ambulation. Okay. Similarly, we should know about what is the most common site. So most common site for deep vein thrombosis is cough vein or soleal vein, and this is usually deep vein thrombosis will lead to pulmonary embolism, which is the most dreaded complication that can take to the life of a patient. So for that reason, we should know about the prophylaxis of DVT. Like we can prevent pulmonary embolism if we know or if we treat DVT prophylactically. So if there is DVT in thigh veins, then there is an increased risk of developing pulmonary embolism. Thigh veins is nothing but femoral-popliteal veins. Okay. So what will be the clinical features in a patient of deep vein thrombosis? The most common presentation will be pain and swelling in the calf region. Okay. Because we all know deep veins of legs. Because of gravity, there will be stasis, and hence deep vein thrombosis will be happening. So pain and swelling in the calf region will be there. Soleal veins again. And then bilateral DVT is seen only in 30% of the cases. Most of the cases it will be unilateral only. Okay. After that, DVT will lead to pulmonary embolism, which can lead to sudden death. So presentation of pulmonary embolism. How will be the presentation in case of pulmonary embolism? DVT is just simple. Pain and swelling in calf region. If the patient doesn't come to you at this level, and if he develops pulmonary embolism, then he will come with pleuritic chest pain, hemoptysis and dyspnea. But where was the actual cause? It was in leg. So hence it is important to identify this condition and treat it. Okay. So low grade fever is typically seen in case of recurrent pulmonary emboli. Okay. So earliest sign of DVT will be calf tenderness, just like we discussed. Other than that, there can be edema, which is initially pitting and then followed by non-pitting type of edema. There will be tenderness along the course of the deep veins. Okay. So there are certain named signs of deep vein thrombosis, like Homan's sign. What does this indicate? There is increased resistance to passive dorsiflexion of foot. If this is a foot, bad with diagrams. Imagine this is foot, this is sole, and this is ankle region. Okay. So dorsiflexion this way. There will be increased resistance to dorsiflexion of the foot. Okay. And then Moses sign, or this is application of pressure over the calf region causes pain. So if you hold the calf off of the patient and press it firmly, there will be pain, and that is called as Moses sign. What is Pratt's sign? If you squeeze it, then there will be pain. That is Pratt's sign. Okay. So if these three signs are clinically evident, then it is a clear case of deep vein thrombosis. Okay. So there are two main complications of deep vein thrombosis which can be identified by looking at the leg. Okay. Those two are phlegmasia alba dolens and phlegmasia caeruleus dolens. So alba, just like we all know, alba means white. It is a painful leg, we all know, and painful white leg. Okay, that is phlegmasia alba dolens. This is because of obstructed deep channels, but collaterals are patent. Because of that reason, it has not undergone cyanosis completely. There is certain part of blood supply left to the leg, and hence it has just become white. Okay. Other than that, phlegmasia caeruleus dolens. Okay, it is a painful blue leg. Here, obstructed deep venous channels and collaterals both are obstructed. Yeah, so these are the two main complications which we can see in case of deep vein thrombosis, that is phlegmasia alba dolens, where the leg is painful and white in color, whereas phlegmasia caeruleus dolens, it is painful leg and it is blue in color. Okay, so why is blue? Because of complete cyanosis, because both deep vein as well as collaterals both are obstructed in this region, in this disease, and hence it will be blue in color. Okay, so how will we come to know that it is DVT? How will we investigate this case? Investigation of choice is duplex scan, but we can do Doppler also. What is Doppler? It is used for assessing moving structures like blood, anything. Okay, so what does this Doppler indicate? It can show if there is presence or absence of flow. Okay, and the direction of flow and velocity of flow. Basically, if this is a blood vessel and we keep a Doppler probe on this, so if the blood flow is from up to down, okay, so this will say if there is blood flow or not. Okay, other than that, it can say the direction of the flow, but direction of the flow usually will be based on this probe. Okay, so if we keep this probe like this, so what it will say, if the blood flow is like this, it will say, okay, it will show in red color. Okay, because it is detecting the blood coming towards it. So if the blood flow is towards the probe, then it will be red in color. If the blood flow is away from the probe, it will show in blue color. Okay, so based on this, we can say if the blood flow, direction of the blood flow also we can say. Other than that, if there is a turbulent flow, it will be showing in green color. So Doppler is investigation of choice for portal hypertension and testicular torsion, whereas investigation of choice for DVT is actually duplex scan. So what is duplex? Duplex is nothing but Doppler. Along with that, there is B mode of traditional ultrasound. Okay, so it is Doppler plus ultrasound. So what is the use of adding ultrasound to this? We will be able to see the vessel wall also and the surrounding tissues also, along with blood flow, direction of blood flow, everything. So by this we can say if the vessel wall is thickened, the condition of the vessel wall and the surrounding tissue conditions also. Hence duplex is used as investigation of choice. In case of DVT as well as in case of varicose vein, duplex is used. Okay. So how do we manage? Just like we saw, mechanical and physio or pharmacological. So pharmacologically, we will start anticoagulants, that is intravenous heparin for 5 days. Also we can start warfarin, which acts after 72 hours, that is from 3rd day onwards. Okay, but for warfarin, dose adjustment is required. So for monitoring of heparin, like if we have to know if the heparin we have given is normalizing the patient's APTT or normalizing the coagulation pathway. For that reason, how can we assess it? For heparin, it is APTT. Like if we have started heparin and we measure APTT, if it is in the range of 1.5 to 2.5, then okay, there is no excessive clotting happening there. Similarly, for warfarin, we will use international normalized ratio, that is between 2 to 3. Okay, so You can remember it this way: wept, that is warfarin, measures extrinsic pathway, and we can use pt for its assessment, or inr for its assessment. Okay. Similarly, hapt, that is heparin for uh, intrinsic pathway, and then aptt is used. Okay. So based on this we can treat the patient. After